So we'll move on to our next topic and our very own Dr. Khalid Mumtaz, whose congratulations of being promoted to Professor of Medicine. He's a co-director of Living Donor Transplant at Ohio State University, and he will be the next session will be combining viral hepatitis and hepatocellular cancer. So take it over, Dr. Khalid Mumtaz.
Assalamu alaikum and good morning to all the participants in Pakistan. I believe that you can hear and see my presentation. Can you?
Not yet. We are working on it. Yeah, we can see your slides.
Just a minute.
Yeah, we can see you now, and we can see your screen, not the slides.
Okay, what about now?
Yeah, we can see your slides now. Thank you.
All right. So I want to thank the organizer of this program and all the participants, including Dr. Alam, Dr. Bilal Hamid, to allow me to present the ASLD 2025 debrief. The topics which are allotted to me are HCC and viral hepatitis. Before I go and talk about these topics, you can see this building. This is our new hospital tower of Ohio State University. I've been told that this is one of the largest hospital building in the United States. Its area is about 1.8 million square feet. It costed us about $2 billion, and it has a capacity of catering about 900 patients. So it's going to be a game enhancer in the central Ohio, and we are looking forward to move to this new building very soon. So I have selected about 5 abstract, and I looked into the novelty of these abstract, and I also looked into what could be the change in the practice of mine and the change in the practice of the hepatologist who I'm going to be sharing with today. So the theme of this debrief is I will start with a study on the HCC screening, and then there were a lot of papers about the role of the multidisciplinary liver tumor board in the HCC management. I look into the angle related to that, and then I will review a randomized controlled trial for the management of post-embolization syndrome in patients with the transarterial chemembolization. This is age of artificial intelligence. There were a lot of papers related to artificial intelligence and HCC prediction. I selected one of those papers as well. And then I will discuss a very interesting topic of role of the immune checkpoint inhibitor in downstaging HCC and post-liver transplant outcome. And if the time allows, I may also discuss outcome of the HCC in patient with Aasld, with Hep B and without Hep B and Aasld alone. So without further ado, this is the first abstract that I have selected. The title is Outcome of the Ultrasound LIRAD Visualization B in HCC Surveillance. We know that for the surveillance of HCC in high-risk individual, there is a recommendation to check the ultrasound every 6 months along with alpha-fetoprotein. The recent focus is on the ultrasound reporting system, what we call as the LIRADS ultrasound reporting system, which has 2 components. One emphasizes on the presence or absence of the lesion. The other one was about the visualization quality of the liver lesion. The consensus on the WIS-A and WIS-C is very clear about what is the next imaging modality. However, for the WIS-B, where there is moderate limitation, the consensus is still not clear. So this study authors studied the clinical outcome associated with the WIS-B in context of the HCC surveillance. So what they did in this study, they selected the patients at high risk for HCC, including cirrhosis or chronic Hep B with or without cirrhosis, who underwent an index ultrasound with WIS-B, which means moderate limitation of the ultrasonologist between March 2020 and August 2022. Radiology database was inquired, and all the patients with Vis-B ultrasound were analyzed. The data was procured from the electronic health record. The endpoint of the interest was interval imaging following index ultrasound scan, with focus on the imaging modality, subsequent visualization scores, and clinical outcomes. This is the demographic and the patient characteristic features. A total of 384 patients with the Vis-B ultrasound were selected. You can see that majority of the patients were from the Asian race, 57%. Majority of the patients, almost 60%, have hepatitis B as the cause of their liver disease, followed by Aasld. And majority of the patients were not cirrhotic, 61%. This is the flow diagram of the Vis-B patient, who were 384. Our group of interest is the US1, which is 347 patients. You can see that their interval imaging majority of the time was subsequent ultrasound at 3 months in 239 patients. Only 42 patients underwent cross-sectional imaging. And out of these 42, 2 patients have either LR4 or LRM or LR5 lesion. Rest of the patients have no lesion of remark. And about 1/4 of the patient have improvement in their Vis-B quality to Vis-A as well. The authors have discussed that among patients with the ultrasound LIRAD Vis-B negative ultrasound, one finding on surveillance ultrasound were unlikely to have HCC detected on the subsequent imaging. As I mentioned, 1/4 of the patient have improvement in their ultrasound quality from Vis-B to Vis-A. However, there are certain limitations of the study which the authors have identified as well. One of the main limitations was the fact that there were 60% of the patients without cirrhosis. So the authors concluded that follow-up multi-phase contrast-enhanced CT or MRI after a US1 Vis-B surveillance is unlikely to yield additional benefit. Consider repeat ultrasound for US1 and Vis-B at 3 months interval. Moving on to the next abstract, the title was Pattern of the Specialty Utilization in Multidisciplinary Management of HCC. It was an experience at 3 destination medical centers affiliated with the Mayo Clinic. What they have done is they have tried to find out the distribution of the specialty involvement, which means the role of the specialty, which was part of the liver tumor board, and what specialty was deriving the main management of these patients. These are the results of this study. They found that there were 6,051 patients with the HCC during the time period of study. Out of those, approximately 4,800 met inclusion criteria. They found that hepatology was the main deriver in the liver tumor board in 51% of the cases, followed by interventional radiology in 14% and medical oncology in 10% of the cases. They also found that interventional radiology was the initial HCC provider for 41% of the cases. Medical oncology took care of the treatment in 30% of the cases, followed by the HPB team, radiology, rad oncology, and the liver transplantation team in only 9% of the cases. IR was not just the responsible party for the first treatment, but they were also the part of the providing the treatment, the subsequent treatment as well. Among patients with the BCLC stage, which were 906, IR was most frequently the initial therapy provider for stages 0 and A, while medical oncology for stages B and C. The authors concluded that the study maps real-world multidisciplinary HCC care pathway. As the treatment options expand, structured tumor boards and shared decision-making remain essential. Interventional radiology plays a central role across the care continuum, and the hepatology was critical for the assessment of the liver disease, and then further management and assessment for the transplant potential and post-intervention care as well. The authors have advised that the future work should examine how specialty involvement impacts outcomes such as survival, transplant eligibility, and the time to the treatment. Moving on to the third abstract, It was titled Artificial Intelligence in Predicting the Risk of HCC in Aasld, Development and Validation of a Predictive Model in 306 Patients. This study was from Brazil. We know that patients with the Aasld are increasingly recognized as being at risk for HCC. Early risk stratification is critical to optimize the surveillance strategies, yet conventional models remain limited. AI offers the potential to integrate diverse clinical and lab parameters, enhancing identification of individuals at high risk. The authors aim to evaluate the accuracy of an AI model based on the routine lab and clinical data in predicting the risk of developing HCC in the Aasld. They aim to create and validate a tool to support the risk stratification and facilitate early surveillance of high-risk individuals. They selected a retrospective cohort of patient 306. Out of these, 129 with HCC were selected as cases, and 177 were selected as the control group. They include the clinical variable, laboratory variable. They include the non-invasive indices, neutrophil to lymphocyte ratio, FIB4, and AST-ALT ratio. They used the extreme gradient boosting AI algorithm was implemented, and the data set was randomly split into a training cohort of 80% and an internal validation cohort of 20% to develop and assess the model's performance. Here are the results. The extreme gradient boost based AI model demonstrated excellent discriminative performance with an OROC curve of 0.90 and sensitivity of 91% and specificity of 84%. The most influential predictors were creatinine, portal hypertension, neutrophil lymphocyte ratio, and LDL cholesterol. When they compared it with the other available predictive models, the only one which was closer was Khalid, which has a OROC of 0.92. However, it has a lower sensitivity of 82% as compared to almost 91% with the Aasld HCC score of this proposed study. The authors concluded that the AI-driven model developed using widely available clinical and lab parameters demonstrated excellent performance in identifying Aasld patients at high risk of developing HCC. By enabling early and cost-effective risk stratification, this tool may support targeted surveillance strategies and improve the clinical decision-making in real-world hepatology practice. The next study was an interesting one. This is what we see in our clinical practice in our patient post-transarterial chemoembolization. The title of this study was Efficacy of Dexamethasone versus N-acetylcysteine in Prevention of Post-Embolization Syndrome in HCC Patients. Post-embolization syndrome is frequent, and it is reported in 7 to 60% of the patients after the TACE procedure. The routine predictors of the post-embolization syndrome are large HCC, non-selective approach, dose of the chemo, and experience of the operator. The treatment mostly is supportive. In this study, the authors proposed a phase 3 randomized control, double-blind, double-dummy, parallel group, non-inferiority study. They compared dexamethasone versus NAC for the efficacy and safety in preventing post-embolization syndrome after TACE. They included the patients belonging to BCLC A and B without macrovascular invasion. This is the flow of the study. You can see that one of the group was given dexamethasone. The other group was given N-acetylcysteine. Dexamethasone was given in one dose of 8 milligram about an hour prior to the TACE procedure. And then they underwent TACE procedure, and after that followed for various outcomes. This is the flow diagram. In the final analysis, they were able to find 40 patients in the dexamethasone group and 38 patients in the N-acetylcysteine group. The outcomes studied were composite post-embolization syndrome, including abdominal pain, nausea, vomiting, transaminitis, and fever, and all of these individual symptoms as well. They also looked into the liver decompensation and anaphylactoid reactions. Here are the results. Majority of the patients belong to CTP A and BCLC B class. They reported that post-embolization incidence was non-inferior between the two groups, 13% as compared to 17% in the NAC group. Here are further results. They looked into the impact of the dexamethasone versus NAC on the post-embolization syndrome and did not find any significant difference in the composite outcome. However, the individual outcomes were improved. In the dexamethasone group, fever reduction was 52% as compared to 28% in the NAC group. Pain reduction was also significantly better in the dexamethasone group, 87% versus 53% in the NAC group. Post-ACE liver decompensation was remarkably low in the dexamethasone group as compared to the NAC, and the phylactoid reaction was seen in about 18% of the patients who received NAC. Furthermore, they see that the disease was stable in dexamethasone group, as well as disease progression was lower in the dexamethasone group. However, it did not reach statistical significance. They also looked into the multivariable analysis for the prediction of the post-embolization syndrome after TACE. Serum ALT was one of the predictor. Among the predictors of the post-ACE liver decompensation, bilirubin and dosage of the chemotherapy stand out as the independent predictors. Here are the conclusion of the study. The post-embolization syndrome incidence was non-inferior between the two groups. However, at 48 hours post-TACE, dexamethasone was associated with a significant reduction in fever, pain, and liver decompensation. Additionally, the anaphylactoid reaction and other adverse events occurred exclusively in the NAC group. Moving on to the next paper, this is an interesting paper, and it is one of the most exclusive, I would say. The title was Pre-Liver Transplant Immune Checkpoint Inhibitors and Post-Liver Transplant Outcomes in 408 HCC Patients. It was a global retrospective study from the LIFT HCC Consortium. Our hospital, Ohio State University, also contributed a few patients to this very exclusive study. We know that immune checkpoint inhibitors have revolutionized the treatment for advanced HCC. Here I have shown two of the studies comparing the impact of two of the immune checkpoint inhibitors along with the TACE compared to the TACE alone, and they found that the combination of the immune checkpoint with TACE is helpful in improving the progression-free survival. The second study on my right, which is the Emerald study, which studied the impact of using Lenva with Pembro plus TACE and compared with the TACE alone, shown also progression-free survival better in the combination group as compared to the TACE alone. So based upon these two trials, there's a potential role of immune checkpoint inhibitor as a downstaging therapy for the liver transplantation. This was the basis of collecting the data for the LIFT HCC consortium. The aim of this consortium was to estimate the long-term overall survival, recurrence, rejection, to identify the predictors of the outcomes, to compare the outcome between patients downstage with the immune checkpoint inhibitor and those always within the liver transplant criteria. As I mentioned, that this was a consortium called the LIFT HCC. It was the first global collaboration including Asia Pacific, North American, South American, and European centers. And the authors have invited all the high volume United States liver transplant centers performing more than 100 liver transplantation in the year 2024. There were multiple data points collected, including the longitudinal measurement of the tumor burden and the alpha-fetoprotein, ICI cycle type, and washout period. Various outcomes were studied, including overall survival, rejection, and HCC recurrence. Coming to the result of this study, there were a total of 408 patients from 60 centers. Majority of the patients were contributed by the Chinese centers, 60%, followed by the US centers, 26%. The mean age of the patient was 55. At ICI start, 75% of the patient have a CTPA cirrhosis. Maximum tumor diameter was 5.5 centimeter. Median alpha-fetoprotein was 53. Majority of the patient belonged to BCLC B and C. 23% of the patients were within the Milan criteria. 91% of the patients underwent loco-regional therapy, and 57% of them received the loco-regional therapy before starting the immune checkpoint inhibitors. Majority of the patients have undergone deceased donor liver transplantation. Various types of the immunotherapy were used, including nivo and pembro is in 69% of the patient, atezo in 25%, atezo and beva combination in 21%. So you can see that there isn't any uniformity in the use of the different immunotherapy. One of the most important variable was ICI washout, which was a median of 73 days. These are the different outcomes which were studied, the tumor burden, alpha-fetoprotein. The tumor burden changes from ICI start to the liver transplantation. There was reduction in the tumor size, there was reduction in the tumor number, and there was an improvement in the Milan criteria from 23% to 43%. Alpha-fetoprotein was also improved. Outcomes after the median follow-up of 21.2 months. Allograft rejection was seen in 19%, HCC recurrence in 26%, and death was reported in 21% of the patient. These are the Kaplan-Meier curve for the HCC within Milan criteria at liver transplantation, and it is showing that it is associated with lower risk of recurrence and prolonged improvement. It is also on my right side, the curve is showing that lower alpha-fetoprotein at liver transplantation is associated with a lower risk of recurrence and prolonged overall survival. These tables are basically showing that patients who were within Milan criteria and alpha-fetoprotein of less than 20 have a better overall survival. 91% 1-year survival, 3-year survival of 84%, and 5-year survival of 84.6%. Similarly, the recurrence-free survival was also best in the patients who were able to achieve within Milan criteria and alpha-fetoprotein of less than 20. The other predictors of allograft rejection were older age. So older age has a safety factor for the allograft rejection. Longer ICI washout beyond 30 days has a protective effect against the allograft rejection. Similarly, the HCC recurrence was dependent on the log of the alpha-fetoprotein at the time of liver transplantation, and also upon the criteria of the Milan. The overall survival predictors were HCC recurrence and severe rejection. These graphs are again endorsing what I have just alluded to. The recurrence predicts shorter overall survival, no recurrence, better survival as compared to recurrence. And then severe rejection predicts shorter overall survival. However, the survival in patients who have mild to moderate rejection was equal to those who do not have any rejection. There were a lot of limitations of this study. First of all, it was a retrospective design study. There was no control group. The median follow-up was shorter, 21.2 months, predominantly Asian population of 60%, and very limited safety factors were checked. The only factor which was checked was rejection. The other side effect related to the use of the immune checkpoint inhibitors were not looked into. However, it was one of the first trial which has looked into a lot of important aspects. The clinical takeaway of this trial are pre-liver transplant immune checkpoint inhibitors are feasible and overall safe. Severe rejection is rare but worsen the overall survival. Traditional selection criteria, including alpha-fetoprotein, tumor burden, and within Milan criteria predictive of the outcome. The status at the liver transplant is stronger predictor than at the ICI start. And the most important message, which to me is something to consider going ahead in my practice, is longer ICI washout beyond 30 days is something that needs to be practiced when you are selecting the patient who are on immune checkpoint inhibitor and undergoing liver transplantation. The future direction could be to do prospective studies with the control group, define ideal loco-regional therapies with timing within immune checkpoint inhibitors, prediction of the responders and the down staging candidates. There is one more paper, one more abstract, but because of the lack of time, I'm going to pass it on and go to my concluding slide. So these are the final take home out of the 5 papers that I have discussed today. In the first paper, I discussed about the ultrasound modality based upon the LIRAD. When you have VIS-B report, based upon the abstract, you can go ahead and repeat an ultrasound in 3 months. There is a 1/4 chance that the VIS-B may convert to VIS-A, and based upon that, you can continue with the HCC screening. In the second paper, I reviewed the multidisciplinary liver tumor board from the Mayo Clinic. It has given us a message that it is very important to keep assessing the HCC management and acknowledge the liver tumor board teams which are involved in the care of these patients. Then I showed you an AI-based model for the prediction of the HCC. Our model, the model of this abstract, which was extreme gradient boost-based AI model, suggested a very good OROC score, sensitivity, and specificity for the prediction of HCC. In my fourth paper, I compared the use of dexamethasone with NAC and found that dexamethasone is helpful in reducing the post-embolization syndrome and liver decompensation at 48 hours. In my last abstract, I talked to you guys about the use of the pre-liver transplant immune checkpoint inhibitor, and the abstract showed that it is feasible and overall safe. Longer ICI washout beyond 30 days is advised. Thank you, and these abstracts are open for further discussion.
Thank you so much, Dr. Khalid Mumtaz. Any questions from the audience? Okay,
Yeah.
we have Dr. Asif and then
Yeah.
Dr. Hassan Nabi Tayyib. Go ahead.
Dr. Khalid, nice presentation. One question regarding the ICI for HCC. So the mention is like ICI should be like they have the longer washout period of about 73 days here, right? So the setting like Pakistan here, like where the mainly the transplant is done in the living donor transplant, right? So at what time they need to be stopped here, right?
So Khalid, I don't know
So
whether you
the study,
you heard the
yeah,
question, right?
I did hear the question, yeah. So the study that I have showed you has suggested that the median time to stopping the ICI was 70 days. However, the analysis has suggested that any time beyond 30 days is associated with a better outcome in terms of lesser allograft rejection and improvement in the overall mortality as well. So I believe that in the context of the live donor liver transplantation, the surgery is most of the time a scheduled surgery. And particularly for the HCC, there is no urgency in, jumping on the surgery. So in the context of the live donor liver transplantation, things are better in control. So based upon this paper, I think the practice would suggest to at least wait for 30 days of washout. The more washout days beyond 30 days, the less are the chances of any harmful effect of the immune checkpoint inhibitors.
Yeah, I think in our center we do 90 days till 3 months for living donor transplant. We are changing for a deceased donor who have more, so minimum is a month for the deceased donor. We stop it because we can't predict when the offer will come in. Most of the time they still end up waiting for more than 2 months. For the living donor, we're still using 3 months mark. Dr. Hassan Nabi Tayyib.
Khalid, excellent presentation, excellent selection of the abstracts. I'm also of the view that 90 days is the right time for living-related donation. And as regards the AI-based HC detection and comparison with the Khalid, since specificity with Khalid is little more as compared to the AI-based HC detection or prediction. Did they check against the other scores as well, like HES version 2 or 3?
As you can see in the abstract that I have presented, they have checked it against the non-invasive markers. The markers based upon the APRI, ALT, AST scores. I'm not sure what scores are you talking about, Dr. Tayyib?
I was the Gallade sensitivity is not all that different, 89% against 91%. So was it statistically significant? And then another prediction tool that we use in terms of scoring system, HES version 2, did they use that as well? Did they check it against that one as well?
No, they did not. If you look at, I'm projecting the slide again. So here is that slide. I hope you can see it.
So they've checked it against AMAP, they've checked it against Gallade.
Yeah, they didn't check.
And
it.
against Gallade, it's closest against the Gallade, 82% against 90 in the sensitivity. But Gallade is more sensitive, 89, more specific, 89 against 84.3.
Correct, yeah, you're right. So they have not checked against the one that you are talking about. But when they checked again Gallade, it is very close to the Gallade. And you're right, Gallade has better specificity, and the score which they proposed has better sensitivity.
Okay. Dr. Amjad Salamat, do you have a question?
Just wondering, with the dexamethasone and the NAC, N-acetylcysteine, so they'd used a single dose. Is that, if I'm correct, they used a single pre-op dexamethasone dose? But usually,
That's true.
In clinical practice, usually people actually continue dexamethasone for quite some, at least 3-4 doses, something like that. I don't know if that would make a difference and would be a wider difference between NAC and DEXA. So
you know that in our clinical practice at Ohio State University and the places where I have worked, we do not use NAC or dexamethasone in this group of patient. And as you can see,
I think Dr. Khalid Mumtaz got muted. Yeah, I think we don't also use anything preemptively or before the chemoembolization. So I think that is something that we have to, but you're right that when they have used it, it's like multiple doses, not one. So that is something. And I think the one thing before we move down this, Khalid, can you hear us about the ultrasound thing? One thing that Dr. Ghazan Nabi Tayyib has an excellent talk yesterday about the HCC in the resource-limited setting. In the US, the Radiology Society, hepatologists, everyone is working together on the guidelines. And I think that is, some work has been happening from this platform. I think that maybe something about the HCC surveillance, about the ultrasound, because the quality of ultrasound is all over the place and how they read it, would be something. Is there some work going on in Pakistan regarding the radiology societies about the HCC? Anything in that regard? Does anyone has any input? Dr. Altaf Alam? Nothing. Nothing that. And is there an active radiology society? Must be. So I think there must be, some, I think Dr. Ghazan Nabi Tayyib, I think would be a good thing to have it, a discussion in that regard from them to have it. Because I get like someone, go ahead.
Yeah, I think there is, I heard, because we had a radiologist, we invited him for an HCC talk, so they're actually looking into that and they're trying to formulate some guidelines on that, but nothing has come up as yet, but they are making an attempt. But I think what needs to be emphasized is that most of the time when we're discussing radiology, it is actually the cirrhotic and the non-cirrhotic livers, because it's very difficult in the non-cirrhotic livers, and plus the size of the tumor. So when we say, usually we discuss overall sensitivity and specificity of the ultrasound in detecting these lesions. But if you have a smaller lesion, the one that really matter actually for transplant and curative treatment, and then you have an ultrasound in a cirrhotic liver, the actually sensitivity specificity is not very high. So as you move to the larger tumors, maybe the sensitivity improves, and when we discuss the overall sensitivity specificity, because on average, it actually overrepresents the picture. I mean, it gives a rosier picture than it actually is. Because we work in a transplant unit, so what we do is in these high-risk patients, we actually do an abbreviated MRI, and we are sometimes surprised because the ultrasound, as you said, the quality and whatever, and we find many tumors which are not picked up with the ultrasound.
Okay, excellent. Thank you, Dr. Khalid Mumtaz, for the excellent presentation, and we'll give a round of applause for Dr. Khalid Mumtaz.